All right, welcome everyone to our 2019 North American Cystic Fibrosis Conference update. This is Elizabeth, the social worker. I'm joined tonight with Lauren, the nurse practitioner, Bree, physical therapist, and Dr. Brown. Several members of our team are under the weather and weren't able to join us tonight, so we'll be filling in for them as we go along. We are happy that everyone could join us. So just a quick overview of tonight's program. We're going to give a quick little update on the ending of our Fun-to-One quality improvement project, and then talk just briefly about our presentations we did at NACFC. Then the bulk of it will be multidisciplinary updates from myself, some nutrition from our hospitalists, some advanced lung disease information, physical therapy, respiratory therapy, and then probably what everyone is waiting for. Dr. Brown is going to talk a little bit about Trikafta and continued commitments from the foundation. As a reminder, please mute your microphones to limit background noise. I think I have muted everyone on my end, but I'm not positive. So just to be sure, if we could do that, that would be great. And please post any questions that you have in the chat box, and we will answer those at the end. And also, we are recording this webinar, so hopefully people who can't join us tonight will be able to watch it later on, or you can watch it again if you enjoyed it.
So the first night in Nashville, we got together with the other programs that were part of our QI initiative for the past almost 2 years that we've been working on quality improvement with our center. And we got to showcase all the work that we've done over the past several months that we were very proud of. And some things we wanted to highlight was that over this period of time, we increased our relationship with our pediatric colleagues, and we do plan to work with them more in the future to improve transitions from the pediatric to adult clinic. In our own center, we were able to roll out our admission tip sheet, which hopefully all of you had the opportunity to see, and we are in the process of revising now. If anyone has any updates for that, we'd be happy to include it. We also increased the frequency of our annual letter for our CF Care Center from annual to biannual. So you'll be seeing another one coming out in the next month or so. And we are very proud that we started our PFAB group, which is our Patient and Family Advisory Board that is up and running with a lot of great ideas. And we also rolled out our PFEC, which is our Patient and Family
Experience of Care survey.
And we're getting a lot of feedback from that, which is helpful for us to make improvements in our clinic. And we're hoping to make further strides with our respiratory care on the inpatient setting. So we're very happy with the work that came out of it. We learned a lot about QI in general, and we have a lot of great ideas moving forward. And if anybody's interested in seeing the work specifically that came out of this project, we have it posted on the wall in clinic across from rooms 1 and 2.
Also at the national conference, we had the opportunity to share some of our hard work through abstracts and poster presentations. So here, Dr. Brown and Melissa and Quinn represented the team well with 2 different posters. I'm going to quickly just show you the posters. It's a lot of information. The first one was about initial pilot results of a novel rapid point of care test detecting Pseudomonas in our CF population, and that is something that some of you may have been asked to be involved in, so thank you very much. And the second was looking at the outcomes and impact of our wonderful CF-specific pulmonary rehab program. And I'll say that I was standing by Quinn when she was presenting this poster during the formal poster session, and like last year, she was having a lot of people come visit her, and they were super excited to see what she's doing here at Inova, and we're trying to figure out how to bring it back to their program as well. So moving right into kind of my social work updates from the conference, a large number of sessions that I went to really focused on just all the different therapy techniques that the different providers are using within the clinic setting. Some of the most popular are the acceptance and commitment therapy, which is fairly new. That focuses on looking at an individual's values and how you can use those values to really be the driving force in their daily actions and what they focus on, rather than maybe focusing on some of the more negative aspects going on in life. For CBT, cognitive behavioral therapy, that is one of the more well-known and well-established techniques that looks at linking your cognitions and your behavior, and maybe how changing your thoughts can change your behavior. It's used a lot with anxiety. There are providers from Mass General and Harvard that are actually developing a CF-specific CBT tool. Everyone was super excited and was asking, how can we get our hands on this? But it is still in its pilot phase, and they wanted to reinforce with us that they would love to get it out to everyone, but they wanted to make sure that first it was something that did what they wanted it to do, and that it was studied and could show that it was both it was reliable and could be repeated. Another one that was talked about a little bit was dignity therapy, and that is a therapy that is used more towards end of life, and it has helped to have individuals reflect and feel as if they have built a legacy or leaving something behind. And then there was also talk about just some brief interventions that can be used either in the clinic setting or at home. And when I say brief, it means that they're kind of shorter interventions that don't take a lot of time, and things that you really don't need. You don't need to be with a therapist or a counselor or social worker to do. So different breathing exercises, progressive muscle relaxation, some mindfulness techniques, and then on the next slide, they provided us with some of their favorite apps that you can download for your phone. Breathe to Relax and I Breathe are ones that focus more on breathing, as stated in the name. These Stop, Breathe, and Think, Calm, and Headspace are apps that focus a little bit more on mindfulness and helping individuals that have more anxiety in their day-to-day life. There are many more apps available. These are the ones that were just kind of highlighted, or ones that have been used more. I think all of them are available on both the store for Apple phones and for Androids. iBreathe might just be for the iPhone, but there is an equivalent for Androids as well. Another topic that was talked about a lot was how physical health equals mental health. And one of the cool things that I found was that the CFRI, which is, I think, a group out of more the West Coast, they have a different wellness programs called Breathe In, Work Out, where it is all virtual and they connect patients throughout the country. So if you're interested in that, check out their website. I don't know if they're currently enrolling anyone in their current sessions, but if it's something you're interested in, check it out. They also have a lot of other programs and resources available to our patients and to their family members. And lastly, I just kind of wanted to highlight some of the different community resources that are available. The CF Peer Connect program provides mentoring for people with CF and their families. You have to be 16 years or older. That is the one caveat to it. And they pair individuals up that might be looking for specific guidance or thoughts on maybe a specific time period or transition in their life. You can go to the website and you can self-refer yourself for that. There's also the CF Legal Information Hotline and the CF Social Security Project. It is based out of Texas. It provides confidential and free information about Social Security eligibility, different benefits, Medicare, Medicaid, health insurance, Affordable Care Act, education and employment questions. And they also can help with free representation when filing for Social Security benefits. I know a number of our patients here in clinic have used them and have found them very helpful. One of the lawyers herself actually has CF, and I think can really relate to our population. And the last one is the COMPASS program, which provides one-on-one assistance for case managers to identify any available resources that an individual might be looking for to help with a specific problem, whether it is CF related or not. Their information is listed here as well. We will be sending these slides out after the presentation, so that way you'll have access to the links and all the information we have here. As I said, some of our team members aren't with us tonight. Erin was not able to make it. She is feeling a little under the weather, but wanted us to share her information. So for her, one of the big takeaways from the national conference is just that CF is changing rapidly, and medical nutrition therapy for CF has to evolve with it. So thinking about the legacy of a traditional CF diet that historically overcompensated for energy-dense, nutrient-poor foods with generally poor diet quality, instead switching your train of thought or thinking how high-calorie diets can be healthy. So Erin posed this question: how long does it take to form a new habit? And this was something that I think they talked about at one of our QI presentations. The answer is 66 days. So she challenges everyone to find one thing from her next slide that maybe you can consider putting into your diet. So this slide, it has a lot of information on it. I'm not going to read it all. Again, we'll send the slides out so people can have them. But for thinking about ways that you can maybe make your diet a little bit healthier, emphasizing healthy fats and incorporating them into your meals, making modifications to meals to make them healthier, finding ways to get electrolytes and calories. So she said maybe some smoothies or milk or supplements instead of just sports or sugary drinks. Choosing whole foods over processed foods to ensure adequate fiber in your diet. Encouraging family-based meals, and to follow guidelines for general population and to modify as needed. There were some updates for your micronutrients that she wanted to share, thinking about vitamin C and its benefits for lung function, how that's similar to A, E, and D vitamins, and how when you're on increased antibiotic use, how this can decrease the effect of vitamin C as well. For vitamin K, if you're on prolonged antibiotic use, that you should, or have liver disease, then increasing your daily dose could be important. For vegetarians and vegans, increasing calcium, vitamin B12, and vitamin D. Sodium recommendations can slightly decrease with new modulators, but it's still recommended that you take in more sodium than the general population. And the number that Erin provides is aiming for greater than 3,000 milligrams daily of sodium. And also thinking about how zinc can be impacted when not taking enzymes. And mild zinc deficiencies can show themselves as reduced appetite, impaired taste and smell, impaired immunity and wound healing, and severe zinc deficiency, hair loss, skin disease, and growth failure. We also wanted to remind everyone about the different vitamin resources that are available through some of the specific enzyme programs and through HealthWell. If you are on a commercial insurance, you should be eligible to participate in your enzyme programs rewards program. And then also a reminder about HealthWell that they recently have changed their eligibility requirements to receive their grants. They have decreased the poverty level that you have to meet, so that actually means that less people are eligible and the money amount is less. I think the hope was that even though less people would be eligible, that they would have more money to meet the needs of those who were eligible. I believe in the past they probably were running out of funds. And then also to look into state assistance programs. Compass is helpful with that, and to know your state's Medicaid coverage. Sorry. So I want everyone to meet Dr. Kate Gibson. She was one of only a few providers across the country to receive the PACE grant through the CF Foundation, and this grant provides opportunities for physicians to learn more about CF. She is a hospitalist here on the APU. It's our 4th floor on IHBI, as well as its co-director, and that's where a lot of our patients go who have not been transplanted. And she got to go with us to the national conference this year.
All right, thank you. So really excited to be here. As Elizabeth said, I'm one of the hospitals here at Inova Fairfax. I've been working here for about 6 years. I've been up on the APU quite a bit for those years, so some of you probably know me. And now I'm one of the co-medical directors up on the floor and received this grant a couple months ago to work with the CF team, which I'm really excited about, and plan on using it to sort of help with kind of the inpatient care of the CF patient up on the APU. So as part of this, I got to go to the CF conference, which was really exciting for me, something new, and I learned a lot. One of the big things that I learned was really kind of the importance of the registry data. I didn't realize how much the registry was really used for a lot of different studies and different things. I just kept hearing speaker after speaker talking about the registry. So it was really interesting to hear how important that is. And I know after talking with Dr. Brown, it sounds like quite a few of the patients in this program are involved with the registry, which is great. One of the studies that, or one of the lectures that I went to where they were talking about looking at a study to see when people are on modulator therapy and they are kind of clinically doing a little bit better, trying to see if you can actually decrease therapies. So two of the things they talked about was potentially cutting back on hypertonic saline and Dornase to see if people still continued to do well while they were on the modulators, if you're able to kind of scale back some of the therapies. So they were implementing a study of that to kind of see how people did. So hopefully more to come on that, but I thought that was pretty interesting. But again, when I was talking with Dr. Brown about this, we said don't do it yet. Haven't decided yet, but there's something that they're looking into. And then one of the other things that I noted that was kind of interesting was there was someone who was looking at kind of diabetes screening in the CF patient and the difficulty in getting glucose tolerance tests done for patients. And so they said, you know, looking at the hemoglobin A1C traditionally hasn't been very accurate in this for CF-related diabetes, but they were trying to see could it be used as a screening tool, whereas if it was below a certain level, would you then say, okay, maybe we don't need to do the glucose tolerance test, and then if it's above a certain level, then you really do have to push for it. So that was one study that they sort of looked into that possibility, and I believe the CF Foundation is looking into it a little bit more. As of right now, it's certainly not a recommendation that they have, but something that they're looking into that I thought was interesting.
So this is Lauren Marinak. I'm the inpatient nurse practitioner for advanced CF lung disease and lung transplant. And I actually only attended a 4-hour short course specifically on advanced lung disease and CF before the conference actually started. And I found it very helpful. We discussed the guidelines for the clinical management of patients with CF when their FEV1 is less than 40%. And this includes assessing the need for oxygen at rest with sleep and with activity, monitoring echoes to ensure the heart is working properly to help deliver oxygen from the lungs to the rest of the body, and checking blood gases to monitor carbon dioxide levels and see if patients may benefit from other respiratory devices such as nocturnal BiPAP. There was also a large emphasis on supportive care for these patients with advanced lung disease, which includes mental health support, optimizing nutrition, and utilizing pulmonary rehab programs, which we are fortunate to have here at Inova. And just like Elizabeth mentioned, the CF Foundation encourages us to discuss the CF Peer Connect with patients with advanced lung disease. This is a program designed by the CF Foundation which connects people with CF as well as their family members to others with similar situations. Pairs can be matched based on where they are in their lung disease, whether they are pre or post-transplant, and they can also match based on life experiences that people are interested in. These may include going to college, starting new jobs, relocating, dealing with relationships, starting a family, or considering transplant. There is an easy online request form found on the CFF website for those that are interested. And they did put a plug-in for patients that may feel like they could be a good mentor for other patients. They often have a lot of patients seeking mentors, but not as many people being mentors. So I did want to mention that. And in the short course, we discussed transplant candidacy, and they put a strong emphasis on centers educating referral centers and pediatric centers about transplant candidacy to allow patients and providers to identify modifiable barriers to transplant early to allow for intervention. Some of these may include BMI being too high or too low, blood sugars being uncontrolled, use of anxiety or pain medications, or lack of social support. And lastly, we discuss the importance of maintaining focus on CF-specific care post-transplant. And this includes diabetes, bone health, mental health, and GI issues. We want to make sure we don't lose sight of these things post-transplant, so our center is working on implementing an annual visit for our post-lung transplant patients dedicated to their CF care. And I feel like this is an area for improvement for us, so more to come on that. A huge takeaway from this course that I had was how lucky we are to have both the CF Center and the Lung Transplant Center under one roof here at Inova. And this helps with continuity of care and communication, which leads to better patient outcomes.
Hi everyone, my name's Bree. I'm an inpatient physical therapist here at Inova who has recently come to the CF clinic on Wednesday afternoons. I have met most of you that I've seen inpatient, I have now seen in the clinic, and I would like to see everyone else as well. So if you can, I would love for you to schedule an appointment on a Wednesday afternoon with me for a PT evaluation. If you're curious as to what this would entail, it is about an hour long to assess your strength, your range of motion, balance, your gait, so how you're walking. It also does include a pelvic floor screening and a vestibular screening, which the last two, the pelvic floor and vestibular screening, is just a series of questions. There's no physical exam required, so just wanted to throw that out there. So next time you're in clinic, or if you want more information about that, let us know at the end. We can direct you in the right direction. So the last two things, the pelvic floor screening, the vestibular screening, I'm going to talk a little bit more in detail about and what I learned at the conference. So a big sector of PT and CF population is pelvic health. There is a high incidence of urinary and fecal incontinence. It's both underreported and undertreated, according to a lot of studies. Urinary incontinence, in one study, was reported in 68% of women, and then from 2 to 16% of men. And with fecal incontinence was 54% in women and 44% in men. Now, from the patients I've screened in clinic, these numbers are pretty high, but it goes to show that it is a big concern in this population, and if it's occurring with you or one of your loved ones, it's definitely something we can help out with and point you in the right direction with. So why does urinary incontinence happen? It can happen because of coughing, posture, weak pelvic floor muscles, and then it can increase in frequency with aging. And why does fecal incontinence happen? It happens from constipation, decreased activity level, coughing, malabsorption, laxatives, or poor posture. So the treatment for either of these, one, you can come to your annual screen with me and I can point you in the right direction for a referral to PT if needed, or to a urologist or urogynecologist. So these next two things I wanted to talk about, very large words and difficult to say. I'll probably stumble over them a few times. But both of them basically have to do with your balance and your hearing. So ototoxicity is basically structural damage to the inner ear by pharmacologic agents. So drugs that you might be taking part of your daily routine or when you come into the hospital. Symptoms that are associated with either of these, ringing in the ears, hearing loss, a sense of pressure. You might have dizziness, imbalance, your gait, your walking might feel a little bit off, or you might have had some falls or near falls at home. Symptoms can be worse in the dark or on different surfaces, so flat surfaces or on grass or gravel or cobblestone. You might feel lightheaded or fatigued, so some very vague symptoms, which you might sometimes attribute to other things. It could be because of this. So vestibular ototoxicity is because of the balance organs in the ear. The main characteristics of this type of toxicity is disequilibrium, dizziness, or oscillopsia. So oscillopsia is a fun word to say, but it means like you have gait, like your eyes feel like they're going up and down when the environment's kind of stable, or vice versa. So cochlear ototoxicity deals with the cochlea of the ear and damage to that area, and is usually results in hearing loss or ringing in the ears. The big takeaway from the conference was the actual cause of these, and it's aminoglycosides, such as gentamicin and tobramycin, which we use a lot in patient. So it can be worse through IV if you're getting a very high dose. If you're using more than one at a time, it can get worse with age, exposure, or insufficient kidney function. So if any of these symptoms sound familiar to you, or you feel like, oh, this might be affecting me, again, come see me, and we can do a screen and get you pointed in the right direction, whether it's PT or ENT. And a lot of times in the clinic, or you might have your hearing screened, but it's not sufficient to tease out the balance issues. So Quinn is not able to be here tonight. So I was going to talk a little bit about the Pocket PEP, which was something she was very excited about at the conference. So the Pocket PEP is a handheld oscillating positive expiratory pressure device for lung expansion and helps with secretion clearance. It creates a positive expiratory pressure when the patient exhales through the device, and it helps to loosen and remove bronchial secretions. Features and benefits. It's very small. It's one of the smallest OPEPs available. It's less than half the size of most other products. It's easy to operate and clean. It meets the CF guidelines for cleaning. There's also an optional T-piece that adapts it for use with most nebulizers. And it can be cleaned with soapy water, dishwater, boiling, or microwave steam bags. It can also be cold sterilized with isopropyl alcohol or hydrogen peroxide. If you're interested in these, please inquire at your next follow-up appointment.
Hi, this is Dr. Brown. We'll segue into the next part of the talk, which will be really cool because we're going to show a video of one of our patients that was shown at the CF conference. But our favorite part of the CF conference is they have 3 really big sessions called plenary sessions, where everybody gets together in one room and there's no competing sessions. And then really important people talk. So this year, as always, the partnership between the CF community members was highlighted as really the fundamental reason why we've had such important scientific advancements, like Trikafta, which is a new drug that was approved, as you guys know, in October. And so really, again, the overarching theme of partnership, and that goes not just between the CF Foundation, but also with families and patients that are participating in research trials, our clinical teams like us, researchers that are doing research in the lab, scientists, and pharmaceutical companies that are actually making this come to fruition. And one of the quotes that I really love that I put up on the screen from the CEO of the CF Foundation, Dr. Campbell, was that money buys science and science buys lives. And that really, I think, highlights the CF Foundation's attitude towards supporting these startup companies they give a lot of money to get them interested in doing research in CF, which is a rare disease, and otherwise people wouldn't be that interested. And that has directly been reflected with the story of Vertex, which is the company that has made all of the modulators and now the Trikafta that was just approved. But also at one of these plenary or big sessions at the CF conference, we were really excited that one of our patients, Claire, who comes here to Inova, that had a video made of her. And this was back in the summertime when we didn't know when Trikafta would be approved. We didn't know it would be called Trikafta. We just knew that there was this triple modulator that was going to become available to people with one copy of the Delta F508 mutation. And so she She just has one copy, so she hasn't had any of the other modulators available to her. And she is giving us her thoughts on the possibility of having a modulator or a pill that she could take to help her CF protein work better. She gives us her thoughts about what that may mean for her in the future. So with that, bear with us, and we want to transition to her video.
If there are any technical difficulties, Jeff, like Dr. Brown said, just bear with us and we'll get everything back.
My name is Claire Tinsley. I'm 25 years old and I was diagnosed with CF at birth. I have one Delta F508 mutation and one W1282X. For the most part of my childhood, my CF was just another kind of fun fact about me. It wasn't something that really was super present in my life. I was definitely pretty healthy, very active. I started...
It wasn't sure.
My name is Claire Tinsley. I'm 25 years old and I was diagnosed with CF at birth. I have one Delta F508 mutation and one W1282X. For the most part of my childhood, my CF was just another kind of fun fact about me. It wasn't something that really was super present in my life. I was definitely pretty healthy, very active. I started singing when I was in 6th grade, I think, and that made a huge impact on my life. School and music were two things that were hugely important to me when I was growing up. My first year at the College of William & Mary, I had my first major exacerbation in the sense that it wasn't the first time I was hospitalized, but it was the first time that my FEV1 really, really dropped. It was a really dramatic change that was eye-opening. It made me more conscious of the fact that I might have to go to the hospital every year and I might have to have IV antibiotics more often. That's just the reality of CF. It's progressive, and it might be, the reality of my future as well. When my doctor told me about the triple modulator, I felt a sense of relief because when you have an illness like this, it's hard sometimes to really think about anything beyond this year, next year. And if the triple could stabilize my health to the point where I don't need to go to the hospital twice a year or more, it would just be a weight off of my shoulders. CF is just something that's always present in my mind. I can't really think about the future, think about jobs, think about dating. I'm definitely very hopeful while trying to keep my expectations in check.
If in your mind you want to take on something else or feel more productive, then I would take on the pulmonary rehab.
My care team at Inova is really great. They've tried different medications with me. The social worker has been amazing, helping me sort of sort through my emotions and the mental health aspect of having a chronic illness. I have always been a very artsy person in the sense that I love going to museums. I love art. I studied art history as my undergraduate degree, and I also love to sing and perform. Singing I can't say how much it's helped, both mentally and physically, with my CF. It's something that when I'm singing, it feels like I have power over this disease. I want to be involved in the community and continue to sing, have a good career, and really give my all to teaching, which is what I want to do. But sometimes it feels like I'm kind of holding on to a rope and just hoping that eventually I'm gonna be pulled up. And the idea that the triple could give me my life back is just in and of itself a really amazing addition to my life. I know that not everyone will be able to benefit from the triple combination, just as I was not able to benefit from previous modulators that came out. It can be difficult to wait and to just be hoping, but the fact that the CF Foundation continues to do this research to really fight for a cure is incredibly encouraging.
I think we're back on. Attempt in the next 5 to 7 minutes to explain how the triple combination works. So bear with me here. So I think the first thing that we have to talk about is the genes. And so this is sort of intimidating, but it is trying to show us the distribution of the different mutations that folks with CF have in the U.S. And this is based on registry data, which is another plug for why everyone should be involved in submitting their data to the registry. But what we can see here is that on the big yellow bar that takes up most of the circle is the mutation Delta F508, which is the most common mutation. And so 84.7% of people with CF in the registry have at least one copy. So I think what's really awesome about the Trikafta or the triple combination is that, right off the bat, 85% of people are going to be eligible. And this is much more than I think, between the other modulators that were approved, we were more sitting around 50 or 60%. So this opens it up to a lot more people with 2 copies and people with just 1 copy, like Claire. So not to get too complicated, but the CF gene makes a protein, and that protein works to, it's called CFTR, and it works to basically hydrate the surfaces in the body, all over the body. So most notably in the lungs, it helps to keep mucus thin and easy to cough up and clear bacteria, but it also works in all the different parts of the body, the intestines, in the liver, etc. So what happens with the Delta F508 mutation is when the protein is made, and the protein here in this figure is depicted as the little purple thing that looks like, I don't know, 2 balance beans or like a hot dog bun together, and it's there in the center of the slide. When it's made in the body, when you have a Delta F508 mutation, it doesn't get into the right position, and so it doesn't fold in the right way, and the internal sort of quality assurance system in the body decides that it's not up to par, and a lot of times it just destroys the protein and it doesn't get to where it needs to be to work. And where it needs to be to work is up at the top of the cell, and so you can see that arrow there showing us how, when it's folded correctly, the CFTR, or the purple hot dog bun, moves up to the top of the cell there, and then chloride, which is part of salt basically, and helps maintain the salt water balance, can flow through it. And so what Trikafta does is it's 3 medicines all combined into one, and 2 of them work as what we call correctors to correct the folding of the protein so that it's not destroyed, and that it can actually get a chance to move up to the cell surface, the top of the cell where it can work. And then the 3rd drug, which is the ivacaftor, helps it open and close correctly so that chloride can flow through and keep everything well hydrated. So 3 drugs in one, 2 to make it fold right, and 1 to make it open and close correctly. And so this is very scientific stuff that was presented at the conference, but let's focus. Let me just try to break it down to the most important part. So the biggest benefit of Trikafta is the improvement for the lungs, as that is the organ that's most affected by CF. And so the top 2 graphs there are people like Claire that were in the study that led to the approval. That was a 6-month-long study, and what we see in the top left panel is lung function. And we all know that FEV1 percent predicted is really kind of the number that everyone hangs on. And so you can see that over the 6-month period, the people who took placebo or the sugar pill, so to speak, are in the gray, and their lung function didn't really change. It started out, 0 is what, basically their baseline, whatever their FEV1 percent was, and didn't really change too much. Maybe in the end of the study, we actually see it fall down a little bit. And then you see in purple the people who were on Trikafta, and you see an immediate bump up in the FEV1 even within the first 15 days, that is on the magnitude somewhere between the, for the entire groups, between the 12 and 15% mark. And you can see that that's sustained, that's maintained throughout the study that was 6 months long. So big separation in lung function there, and happening pretty early, just within 2 weeks of starting it. If you move over to the top right panel, bottom line there is we're looking at pulmonary exacerbations leading to either needing IVs or being in the hospital or some sort of treatment. And again, the gray is placebo, and you can see that they had overall more exacerbations, and then in the middle there, more leading to hospitalizations and more leading to IV antibiotics. And then the purple are the folks that were on Trikafta with less of all three of those things. So that's really good. And we know that lung function over time falls in CF due to exacerbations. So if we can reduce the amount of exacerbations that folks are having, then we can hang on to lung function more over time. So that's really important. At the bottom is people with 2 copies of Delta F508, and basically everyone took the equivalent of Symdeko, which is 2 out of the 3 drugs in Trikafta, tezacaftor and ivacaftor. Everybody took it for a month, and then you can see at point 0 there, one group continued just on the 2 drugs, and the other group in purple got the 3 drugs. And you can see again by day 15 a big jump up in lung function, even above the benefit of Symdeko, in separation between the 2 groups. But these were much shorter studies for people who were already on Symdeko. This one in particular was only 4 weeks long. So really exciting. So the question that everybody on the individual level wants to know is what benefit am I going to have for my lung function? And I think it's really individualized, that some people are going to have more of a bump up in their FEV1 than others, and we don't know until we're on the medication. And so this just sort of breaks down on the y-axis, we see total number of patients, and on the x-axis, we see change in lung function. It's a little bit confusing, but if we start in the middle of the graph, you can see where it says 0 to 5%. So that's pretty much at the bottom middle, or 1, 2, 3, the 4th over from the left, where that's pretty much the mark of, we're going to see how many people in each group, either gray placebo or blue the drug, had basically over the 6-month period, they were within 5 points in a positive direction of 0 to 5% of FEV1 of where they started. And then if we move our eyes to the right, we can see that there's a lot more blue bars. So the next group over were the number of patients that had a 5 to 10% improvement in their FEV1. The next group over, 10 to 15%, and then all the way up. And you can see that there were a few patients in the study, but numbering about 10, that had a really dramatic increase, 30% improvement in their FEV1. And so, but certainly most people, you could see in the blue, settled out around 10 to 15% better than where they started. This is another complicated graph, but let's only focus on the top. And the top left is our sweat chloride test, and we know that that's mostly used to diagnose people with CF, and that's based on, you make somebody sweat and you measure how salty their sweat is, and then based on that threshold, we can make the diagnosis. So what we see in the top left is that once people started taking the drug, the purple group, again, the triple combination, they had about a 40-point decrease in their sweat chloride that was maintained through the study. And the group that wasn't taking the drug had basically a flat sweat chloride, which is what we would expect. It didn't change. In the middle there is the CFQR results. And the CFQR is a quality of life survey that looks at a couple of different domains or areas of life, and you get a score. And the higher the score, the better. And in the past, we've been really excited about a 4-point improvement when we've looked at different therapies. And that's what that aqua dotted line shows, is that from starting at ground zero, if you can improve your quality of life score by 4 points, we get excited. And what we see with the purple, the group on the triple combination, is that there was an improvement more in the range of 15 to 20 points, and it was pretty sustained over the 6-month period. And then that was compared to the placebo group, the gray, that sort of actually had a little bit of a drop off in their quality of life during the study. So pretty impressive. And then the top right is looking at weight and the ability to gain weight. So body mass index, as we know, is weight for height. And what we can see, again, that purple group soaring way above over the 6-month period, at able to gain more weight compared to the group that was not on the drug in gray. And so the next question would be, if it's so great and it's giving us these great results, what are the side effects? And so these are the most common side effects that occurred, or what they call adverse events, or AEs, during the study. And we can see at the top that the most common one in both groups was having a pulmonary exacerbation, which is part of CF. If you sort of compare left to right on the columns and the purple, we can see that there were headache and diarrhea occurred more in the group on the triple combination, but the rest of the stuff was pretty evenly split, or occurred more in the group on placebo. So in general, so far in clinic, when we've been prescribing and seeing people back on Trikafta, people have done pretty well with it. And the one thing I will note is that the second one, the sputum increased, which was slightly more in Trikafta. It seems to be in the first week or so, when you first start taking the drug, that maybe because everything's getting better hydrated, that the floodgates are opening and the sputum is coming up more at first, but then that seems to die down. So we're finding that patients are not having too many side effects with this drug. Okay, so, but we have to be reminded that between this drug, which we know is available for about 85% of patients, and the previously approved drugs, Kalydeco and Orkambi and Symdeko. Orkambi and Symdeko are basically going to be gobbled up by Trikafta, because Trikafta works 3 to 4 times better. So anyone on Orkambi and Symdeko will be switched over. For those who are on Kalydeco, if you have a Delta F508, you can move over to Trikafta, and that will probably offer a little bit more of a boost. But if you don't have a Delta 508 and you remain on Kalydeco, that's probably an additional 5%. So we are now looking at 90% of patients that have one of these modulators available to help their CF protein work better, which is awesome. But it is, it's difficult when people come in the clinic and are excited about this, only to find out that there's 10% of folks that this does not apply to. So what we were encouraged to hear is that the CF Foundation has committed $500 million over the next 6 years to make sure that they continue to work hard on this 10% that doesn't have the ability to benefit from the modulators. Remember, these modulators help people who make protein. They help the protein makes work better. And so these additional 10% of folks that don't benefit from the modulator don't even make the CF protein. So somewhere in there in the gene process, the gene gets turned off and protein is not made. So you can't even correct the protein. So what we're going to be looking at for this additional 10% is correcting things at the gene level. And that they're looking at many different ways to do that, and it's going to be complicated, but I think, again, like we said, money buys science and science buys lives. So $500 million to help this 10% of patients and to not leave them behind is encouraging. Lastly, we just want to bring it back home to our program, and we're looking at, we're almost at the 3-year mark of our accreditation from the CF Foundation. And you can see that since 2017, we have continued to grow very nicely. And the blue bar graph there, the blue bars are our total number of patients. And this includes people who all the way from have normal lung function and pretty normal lives, all the way to people who have had a lung transplant for their CF and continue to see us about other CF issues, including sinuses and GI, etc. So we've had just about 21% growth since last year alone, and you can see we've over doubled in size. So we continue grow and embrace our growing team. And that team is possible in part by support from the foundation, which brings me to the light blue bar in front, which are the number of people who are participating in the CF registry. And that registry basically tells the CF Foundation what's happening with patients around the country, including at our program. So a little plug, if you have not agreed to participate in the registry, please do, because we get a lot of our financial support and other support from based on how many patients are willing to share their data. It doesn't involve anything different than regular CF care. It involves allowing us to enter anonymous, de-identified data to help make sure that the CF Foundation captures everybody in the country and knows where to put their money. So with that, I think that's the end, and we will look for questions.
You actually probably can unmute people, so that way if you want to ask a question, I don't know, that would be easier too.
Type it or ask it. So far, I don't see any typed questions.
So far.
I can start us off as if people are shy. Anybody have a question?
I guess I have one thing to bring up, and that is, are they going to be doing research to see if this will be helpful post-transplant?
Good question. That was a planted question, because I was going to say the same thing. So those studies that we just went over the data for did not include people who have had a lung transplant. And Trikafta, really the greatest benefit is in the lungs, but we believe that there's going to be additional benefits as well. And we saw that with weight, and we saw that with quality of life. But weight and quality of life are different after transplant. So the question remains of, will patients who have had a lung transplant really need Trikafta? Will it justify the expense? Will it interact with the transplant medicines? And those are all questions we're thinking about. I think what we're saying right now is on a case-to-case basis, case-by-case basis, I am open, I think we are all open to considering prescribing Trikafta, especially for patients who have had lung transplants but continue to struggle with a lot of sinus or GI issues like bowel blockages that land them in the hospital, that keep from gaining weight, that ruin quality of life, sinus issues that keep bacteria from the sinuses draining into the lungs, compromising lung health. So I think we're open to it. The main drug interaction that we know about is with the antifungal medicines, and those antifungal medicines are usually used most in the first year after transplant. So perhaps we'll be looking to start people who are a little bit beyond 6 months or beyond a year who are struggling with some of these issues on Trikafta. So I think let's talk about it when you're next in clinic, but we're open to it. We don't have a lot of data to guide us, but we can certainly learn together and make sure it's safe. Anyone else want to type or say a question?
Yeah, I typed in a question, but I guess you can't see it.
Oh, hold on.
Sorry, I'm failing at scrolling down to read it.
Oh, there we go. We do see it.
There we go. So the question is, do they have any idea about how the long-term effects of Trikafta, whether our bodies or lungs will get immune to the drug?
No, I don't think, the data I just showed you was, the really intense study was for 6 months for people with one copy of Delta F. And we looked at those results. There were people beyond that, they rolled over into what we call an open label extension, meaning everybody in both groups got to start taking the drug and continue on the drug until it was approved. So probably there are people who have been continuously on the drug, I would guess the earliest group maybe for a year and a half, but they have not published what that looks like. It is encouraging that over the 6-month period, we see that all the benefits are sustained. The weight and the lung function jumps up really early at, by the 2-week mark, and then it looks like it's maintaining over 6 months. I don't think there's any reason to think that we would become, that the body would become immune to it, or the drugs wouldn't help the protein fold correctly after time. But those are really good questions. I think that there's going to be a lot published, even though now it's FDA approved. What about other things like we talked about sinus and GI issues? Is it going to help with diabetes? Is it going to help with female fertility? There's a lot that we don't know, and that I think we'll see a lot more being published over the next couple of years. What I think on a population level that it's going to, especially for the younger that kids start to take it. Right now, it's only approved starting at age 12, but that'll probably change over the next couple of years. But what I'm hoping is that people will have advanced lung disease and need lung transplant later in life. And that, so I think that the sort of the face of CF will change, and it'll become, we already know it's predominantly adult, it'll become even more so. I expect that life expectancy will take a big bump up. And we've already seen a lot of our patients coming back on Trikafta, just, most importantly, feeling so much better and having better quality of life. So we have, it's certainly not a cure, and we can't drop all of our therapies or the other therapies and say that we're done here. But I think it has really positively changed everybody's life who we've seen back in clinic on the drug so far. But the longer term, right after 3 years, 5 years, that we will unfold with time.
Thank you.
Thank you. We are cautiously optimistic, as we say. Another one. And we got another one. The question is, does Vertex, which is the company that's making Trikafta, have any plans for testing it in lung transplant to answer some of those questions? I don't know, but we would definitely sign up to participate. And I will, what we can do is reach out to our medical science liaison and ask that very question. Not that I've heard of, but I hear from different sources all around the country that transplant programs like ours are, everybody's sort of doing a case-by-case basis. Everybody's keeping an open mind, but nobody's categorically starting everybody on the drug, or nobody, probably nobody's saying absolutely no as well. But I think a study would be the way to go. Thank you for asking that. Okay. With that, we want to thank you for tuning in and participating live, and we hope if you're listening again in the future, or for the first time in the future, that if any questions come up that we haven't covered here, please reach out to us via email or at your next clinic appointment, and we'd love to hear your thoughts on these issues. And we thank you again for your ongoing collaboration, and we look forward to 2020.